All right. I see that everyone is starting to join us on this beautiful Wednesday. Welcome, everybody. Thank you so much for being here with us for our Connectionology webinar. My name is Ginger, and I'm the Executive Director of Connectionology. It is an honor to be with you today, and I am very excited that we've got Caroline here with us. We've got Dr. Benson back with us. We just saw him recently at our Idaho TBI seminar. He's phenomenal, and hopefully you've had a chance to watch some of his past webinars with us, but you guys are in for a treat today and you are going to learn so much. So please ask questions. We will answer them as we go along in this webinar, but also you're going to meet our amazing partners during our break. You're going to meet HMR, Fox AE, OnPoint Legal Nurse Consulting, as well as Stratejic Relationships. Some of our favorite companies. We love working with these teams, and you guys are going to have a great time today, and you're in good hands. I'm going to go ahead and get started because I wanted to introduce Miss Caroline to you. You've probably seen her before in some of our webinars, but she practices personal injury, wrongful death, and product liability with our beloved John Romano down in West Palm Beach with the Romano Law Group. And she has extensive experience handling a wide variety of lawsuits involving pedestrian injuries, motorcycle crash cases, traumatic brain injuries, premises liability, as well as motor vehicle collisions. And she has successfully obtained millions of dollars in settlements and verdicts for her clients. And her passion for medicine and helping people allows her to maximize those amounts recovered for her clients who have been hurt or even killed. And as one of the firm's attorneys, she always takes time to understand everything about the case. She provides personal communication, always to ensure that her clients are afforded aggressive representation. She graduated from the University of Florida with a BS in Spanish literature, and during her undergraduate studies, she performed a lot of medical research at the McKnight Brain Institute at the University of Florida before deciding to attend law school. And that's where she ended up completing her JD at the Levin College of Law, graduating cum laude. And she speaks Spanish and Polish fluently. And she also lives there in Lake Worth, Florida with her husband and her beautiful beloved dogs. So Caroline, we are excited to have you with us today. And I hope everybody has a great webinar. Thank you for joining.
All right, thank you, Ginger. And the real star of the show today is Dr. Randall Benson. It is my honor to introduce him. He is a globally regarded behavioral neurologist and imaging neuroscientist. He is recognized for his advances in the diagnosis and treatment of brain disorders. During fellowship at Mass General Hospital in the 1990s, he pioneered the use of fMRI to map language in neurosurgical patients with tumors and epilepsy. Then, while faculty at Wayne State University in the 2000s, his research using electrical and magnetic stimulation of the brain in hemiparetic and aphasic stroke demonstrated proof of concept for the ability to induce neuroplasticity. It's really special that we have someone like him with us today. He's not only helping patients to get better, but he can also be an expert witness on cases. Most recently, Dr. Benson's clinical practice and research has focused on more precise diagnosis in head-injured patients, leveraging newer functional neuroimaging, neurosensory, and pituitary evaluations, culminating in more effective treatments and improved outcomes in patients. So it is my honor to hand it over to Dr. Randall Benson.
Well, Caroline, thank you for that wonderful introduction. It's nice to know that you have a brain research background. If you're ever, looking for a job, I could use somebody in the lab. Anyway, you're probably happy doing what you're doing. Okay, so I'm going to do a share screen, and hopefully we can get the show on the road here. Let's see if this is the right talk. Yeah. Okay, it should pop up soon. Okay. Let's see, slideshow. On the big guy. Okay, can you see that okay, Caroline? Okay, good. All right, so I don't like to give myself too much time between preparing my slides and the talk. I like things to be fresh. So I changed the title about 10 minutes ago. I think it's more reflective, really, of what I'm trying to get across to you. So the title of the talk is Mild TBI. It's not all about the brain, but it is about the damages. All right, so that pretty much says what you're going to hear over the next hour or two. What I want to convey to you is that what we know now is that mild TBI is not just an injury to the brain itself. In fact, most of the time, the brain injury itself is not catastrophic in these milder cases, and people actually recover well from the brain injury. It's these other issues that keep people from recovering well, and it's really important that you, as personal injury attorneys, understand that, because if you don't, you're going to be missing a chunk of the damages, and it's going to be an uphill climb. We do have objective means of making these diagnoses, and obviously it adds to the life care plan. All right, so I am in Pinellas Park, which is pretty much between St. Petersburg and Tampa. That's where my office is. Um, and you can see my website is here. Contact information. I have another slide at the end, but call this phone number and speak with Brent if you have cases to refer. All right, so let's start with I guess a definition. I think of mild TBI, which is effectively synonymous with concussion for most people. I think of it as a syndrome, not a disease, not a disorder. What do I mean by that? Well, first of all, the notion of a mild TBI, it's a naive term. It implies that it's injury to the brain itself. Well, you already know from what I've told you that there's more going on. There's more than meets the eye. And it also explains why mild TBI has been controversial, resulting in a lot of consternation, a lot of polarity between plaintiff and defense experts, and we know it clogs up the courts, and it's been an issue. Whereas the more severe brain injury, not so much, right? You can see it pretty easily on brain imaging. There's just not a whole lot of controversy regarding severe brain injury like there is mild. So medical experts have very divergent opinions, and of course it has to do with which side of the fence they're on, who's paying them, and all that. We know that. The key is the search for objective medical evidence. It's not so much he said, she said. It's not hearsay. It's understanding what the lay of the land is, and being able to objectify the injuries. And I'm going to convey a lot of that to you today. Some of the evidence for these other injuries relies on some cutting edge technology. And some people are aware of it, some people aren't aware of it. We do face Daubert hearings sometimes on the DTI, but even the DTI has really had a run of success, and we don't see as many attempts to limit testimony as we used to in the old days. Symptoms may be out of proportion to demonstrable brain injury. What do I mean by that? Well, the brain imaging, and I'm not going to talk about the brain imaging that we do routinely today, because that's a whole separate talk. I've given that talk before, and certainly Connectionology has that talk archived if you're interested. But the bottom line is that the imaging is so advanced now between DTI, volumetric, SWI, that we really are in a good position to be able to say whether somebody has suffered much injury to their brain or not. All right. So in in a real true sense, the imaging is just as important for what it shows you as for what you may not see in a given patient. Meaning, if you don't see much, it probably means there are other issues that are operative, and that the brain injury itself was on the mild side. You're going to hear me say that a lot. Okay. In fact, what we're talking about is if the imaging is negative or close to negative, and by negative, what I really mean is it doesn't really deviate from the norm, from our normative group. Doesn't mean there's no brain injury. It just means that it's not enough statistically to be an outlier, right? So that I can't sort of put my signature on it and say, yeah, this person likely has a brain injury because the imaging demonstrates significant abnormalities. Okay, now these other injuries are what I am sort of colloquially calling non-brain neurostructural injuries. So inner ear, vestibular, pituitary, peripheral nerves like the cervical plexus, or vascular structures. Brain injury may be minimal, and what I want to say is that absent these other injuries, these non-brain injuries, people generally do well. So MTBI.
Dr. Benson, we have
Yeah.
a question just before you move on from DTI. Could you explain generally what is DTI, MRI? Is that something that every person who suffered a TBI, or maybe you think they suffered a TBI, is that something they need to be getting?
I don't know that everybody needs to get it. Certainly, it adds to the sensitivity of MRI. It is a technique that can detect damage to the white matter fibers of the brain. What we know is that particularly these high-speed collisions, car accidents, where the person maybe has minimal or no loss of consciousness, but we know the brain, has been, shaken up because of the forces. Those people more often have white matter injury than gray matter injury. It's not something that's easily seen, certainly not with CAT scan, which is notoriously insensitive. Regular MRI, what we call conventional MRI, is only about 25% sensitive, which means about 75% of people have MRIs not showing anything, even though they have what we call a diffuse axonal injury. DTI, what it brings to the party is the ability to identify white matter fibers or white matter bundles that have been damaged. Their membranes are disrupted, the water flow properties are altered, and we can see that on DTI. So it's another way of increasing the sensitivity or the ability to detect injury. Okay, so as I said, mild TBI, is a syndrome. It's not, it's not solely damage to the fibers of the brain. It's what I call a gemisch, which is a Yiddish word for gemisch, right? Kind of means what it sounds like. It's a mix. It's a mixture of things. And so the imaging may not really be terribly um, uh, significant unless it's a more severe injury. But the point is that your patient, your client may have real severe symptoms. They may be, effectively disabled, unable to work, unable to participate socially, and yet their brain imaging is showing virtually nothing. How do we square this? Uh, well, the symptoms do fit distinct syndromes. They're not random. And it's not all depression, it's not all psychological stuff like the defense would make it out to be. These syndromes, and we're going to talk about them, are caused by distinctly different injuries, meaning different tissues. Unfortunately, the knowledge base of most docs doing brain injury medicine um, tends to be sort of rooted in literature from 10, 15, 20 years ago. They tend to ascribe all of the symptoms to the brain, and they'll say, well, the brain's not well understood. So, we can't explain why you're still symptomatic. We can't explain why you're having these symptoms. And they'll typically say to somebody with a mild TBI, well, you'll be fine in 3 months. Then they say, well, it's taking a little bit longer. You'll be fine in 6 months. And then a year comes and patient hasn't improved much at all. And maybe they've gotten worse. And that's typically when the depression hits, because they've been promised a bill of goods and they're still waiting for it. All right. So, it sort of leaves what I say is a convenient and lazy justification for all the symptoms that these patients have, right? Just saying, well, we don't understand a lot. We're still in the dark ages. Well, I'm here to tell you that's not really true. All right. Here's another myth. Another myth is this notion of the miserable minority. The miserable minority dates back to the mid 2000s, and Ron Roof published an article indicating that it's only about 15% of people that don't recover well from a concussion, an uncomplicated concussion. Well, that's not true. More recently, 2017, McInnes and colleagues published a meta-analysis, which I think conclusively shows that it's only about 50% of people with concussions recover well after 1 year. All right, so don't buy the Kool-Aid. So the conclusion is about half of individuals with a single mild TBI have long-term impairment, right? And who does that leave? Well, that leaves our clients, who haven't recovered according to the so-called rule, right? And in fact, I just did a rebuttal on a case where I think it was the neurologist said everybody recovers from a concussion at 3 months. Really? Come on. All right. So we know that's not true. Most of these people, meaning the people that don't recover, have these additional non-brain neural injuries, right? So it's really important in your clients who are a year, 2 years out and still suffering, that you understand what these things are and that we objectify them. Symptoms associated with mild TBI. All right, so now these are sort of classic symptoms of TBI: memory and cognitive, sensory, photophobia, meaning sensitivity to light, hyperacusis, sensitivity to sound, abnormal sensitivity, ringing in the ears, reduced sense of smell, maybe taste, balance, gait, dexterity of the fingers and hands, psychological symptoms, irritability, anger, depression, etc. Constitutional, fatigue, insomnia, hypersomnia, weakness, reduced libido, dizziness, altered metabolism. We hear all of these symptoms from our patients. Some of them get better, some of them don't. Clues that a concussion might be present: loss of consciousness, post-traumatic amnesia, confusion at the scene, right? If you have this stuff, you got somebody, you have a client who had a concussion, right? It's unequivocal, no problem. But remember, the other side says, if it's a mild, they're going to be fine at 3 months, at the longest a year. Fractures of the face and skull, fractures of the shoulder girdle, whiplash injury of the neck. Now, this is really important. If you've got somebody with a whiplash, there is a good chance that they've got at least a mild brain injury. Memory problems, forgetting appointments, personality change, right? So personality change, is really important. It's certainly the baseline is important. But if everybody's telling you that patient is not the same personality-wise, sit up and take notice. Delta V. So we're talking about acceleration or change in velocity. The higher the forces, and if you have direct head impact, more likely it is you have a brain injury. Others in the vehicle with a TBI, right? Because they're probably exposed to the same or similar forces as your client. Head trauma is not all about the brain. Okay, so this is where I'm going to lay out these other types of damages: pituitary insufficiency or pituitary injury, binocular visual dysfunction, which can be caused by either brain injury or inner ear injury, but it manifests as visual symptoms, but not just visual symptoms, as we'll talk about. Auditory vestibular. All right, here we're talking about the inner ear, not the brain. Autonomic dysfunction. The lesion or the damage can be in the brainstem, or it can be outside the brain entirely in the cervical plexus. But these are all damages that result from trauma. My sort of idiom is trauma is an equal opportunity offender, meaning there are plenty of different kinds of tissues that can be injured by trauma. All right, so here's my obligatory Venn diagram. All right, so brain injury is here. Well, what you see is symptomatically there's a lot of overlap. Not 100%, but pituitary overlaps somewhat with brain, somewhat with dysautonomia, somewhat with PTSD. Inner ear symptoms share symptoms with brain injury and PTSD. And this binocular visual problem can be rooted in either brain injury or inner ear injury. So you see, it's a complex web. All right, let's start with pituitary. All right, so the pituitary sits right smack in the middle of the head. It's suspended by the hypothalamus right here. This is the pituitary. Pituitary is protected, quote unquote, by virtue of its being situated in this hard, bony fossa called the sella turcica, right? So it's encased on all sides, not just the front and the back and below. All right, so there's the anterior pituitary that we're going to talk about today. There's the posterior pituitary, which is really an extension of the brain. It's comprised of neurons, but not so the anterior pituitary. All right, here's kind of another view of it. All right, the hypothalamus, the infundibulum or the pituitary stalk, the posterior pituitary that we're not going to talk about, the anterior pituitary, and again, you can see it's sitting in this Turkish saddle. That's a translation of sella turcica. All right, now the pituitary is the master gland in the body by virtue of the fact that it releases 9 different hormones, which get into the circulation and get transported to wherever their effector organs are that have receptors that bind to a particular hormone. So growth hormone, ACTH, that turns on the adrenal to release cortisol, which is a stress hormone, TSH, which turns on the thyroid to release thyroid hormone, FSH and LH, which turn on the testes and the ovaries. In the case of the testes releases testosterone in response to FSH and LH. And if there is a reduction in FSH and LH, testosterone will be low. And prolactin. And then there are the posterior pituitary hormones that we're not going to discuss. They're not necessarily relevant for our cases. Okay, so what do we know? Well, we know that the hypothalamus has these neurons that releasing factors that then diffuse through this loose network, this portal vascular system, and ultimately reach the anterior pituitary cells, and they trigger the anterior pituitary cells to release their hormones. There are a number of different pituitary cells that release these different hormones that we've talked about. I just want to make a point that the association between TBI and low pituitary output is a relatively recent observation, and that's indicated by looking at PubMed, where you see almost nothing, just basically noise, a few case reports, and then around 2005, which I think you'd agree is recent history, that's when things started to take off. So I'm going to just sort of run through this. This is pretty much just saying the same thing a different way. 2005, this is important, consensus guidelines on screening for hypopituitarism following TBI. All right, so this was issued by the Endocrine Society 2005, 2011, Evaluation and Treatment of Adult Growth Hormone Deficiency and Endocrine Society Clinical Practice Guideline. So again, don't be surprised if your colleagues don't know about this. Don't be surprised if the docs that you're dealing with don't know about the association between head trauma and pituitary insufficiency, particularly in the milder cases. So what do we know from the literature? Anterior pituitary dysfunction is reported in 28 to 80% of people with TBI. Well, even if you take the low end, you're still talking about a third of people with TBI having pituitary dysfunction. And if you look at the high end, right, I mean, it's a lot of variability, a lot of methodologic variability across studies. But, you know, what that says is some people are finding that it's really common. Longitudinal studies seem to indicate that on average, about 45% of people with TBI have pituitary insufficiency at 3 months. Some of those people resolve, but you're still talking about 30% at 1 year. All right. So if you've got somebody that you've screened for this and they're symptomatic, and we're going to talk about the symptoms at 12 months, it's time to do something about it. It does not correlate well with TBI severity. That means that you're just as likely to see anterior pituitary insufficiency in milds as you are severes. I can tell you in my experience, it's more common in milds than severes. Tends to be a different mechanism of injury. I think that may explain it, but I'm also seeing these people that don't get better. And so I think there's some selection bias there, referral bias. Rate of hypopituitarism increases with repeated head traumas. No surprise. If one can do it, certainly the more you have, the more likely it is that you see it. So we see it a lot in football. I've looked at over 100 former NFL players. I believe this is a little bit of speculation on my part because I haven't tested everybody, even though I wanted to. I believe that maybe as high as 80% of former NFL players have some degree of pituitary insufficiency. A colleague of mine who I had the opportunity to meet a couple of weeks ago at the endocrine meetings, he's from Turkey, looked at boxers and found a high rate of pituitary insufficiency in boxers and treated them successfully in some cases. So generally it presents in the first year post-injury. This is not something that shows up later, although I have to tell you that people tend to get worse symptomatically with this. If you've got a client and what you're hearing is that your client has gotten worse over a year or two, and they have prominent symptoms of fatigue, insomnia, clouded thinking, there's a good chance they have this. Because brain injury doesn't generally, if it's just the brain itself, it doesn't behave like that. Brain injury, as a rule, improves, via neuroplasticity. Growth hormone deficiency and secondary hypogonadism, meaning low testosterone, in the case of males, shows the highest rate of spontaneous resolution, but that resolution should occur by 1 year. If it doesn't occur by 1 year, the literature says it's not going to, and people remain deficient in one or more of their pituitary hormones. Now, again, the defense will say, oh, you don't get isolated growth hormone deficiency. That's just patently false. We know that isolated growth hormone deficiency is the most common type of pituitary insufficiency. And isolated occurs 2 to 3 times more commonly than multiple hormone deficiencies. And there are reasons why growth hormone tends to be at the top. And a big reason for that is if you look at a cross-section of the pituitary, what you find is that the growth hormone producing cells are on the outside. They're on the lateral aspect of the anterior pituitary. Now remember, the pituitary is sitting in this hard, bony structure called the sella turcica. The pituitary is certainly at risk for contusive or focal injury on the surface of the gland, which happens to be where the growth hormone producing cells live. Now, it doesn't mean that you knock out all of them, but you may in fact damage some on the outside, which may cause the patient symptoms, and we can detect that on growth hormone stimulation testing. Another mechanism besides the focal injury model is more acceleration, deceleration. And the idea is that with flexion and extension of the neck, there's this tugging that goes on the pituitary stalk, and that is likely to cause damage to these blood vessels, which, as you recall, carry the releasing factors down to the pituitary. So if the neck is damaged, it's also likely. Furthermore, if the hypothalamus is damaged from the trauma. So essentially, there are three potential targets for injury to the pituitary, and one is outside the pituitary itself. It's the hypothalamus. The other is the pituitary stalk, and then finally the body of the pituitary gland itself. What are signs and symptoms of low growth hormone, which, as I've told you, is the number one most common deficiency that we see after head trauma? Fatigue! Exclamation point. These people, not only do they have physical fatigue and decreased endurance, they have mental fatigue. They fatigue within 30 seconds of focused concentration on task. And I know that because I test them for that every single time. And so it really is a good discriminator of people with metabolic problems, because growth hormone deficiency is a metabolic problem. It essentially deprives the neurons of a nutrient hormone, causing these neurons to become refractory or to fatigue. And that's why what we find is that our clients tell us that they can only concentrate for a few minutes at a time, and then they have to take a break because they just can't make hide nor hair of what they're doing. So stamina, lack of motivation. I call this bump on a log syndrome. These people who they lay in their reclining chair staring at the ceiling, or just sort of blindly clicking their remote on the TV. I saw somebody like that yesterday, who used to work a 10-hour day as a welder, and now he can't do it. I mean, he's got some dizziness problems, but mostly he's got zilch motivation, zilch ability to concentrate. Hasn't worked in over 2 years. Weight gain. All right, so the guy from yesterday gained 100 pounds. That's a little bit outside what we typically see, but what we typically see is with men, it's about 30 pounds. With women, it's about 15 to 20 pound weight gain. And it tends to be central, meaning abdominal fat. At the same time, these people are losing muscle mass and strength because growth hormone is required to maintain muscle mass and strength. So similarly, this guy yesterday, who was a football player in high school and just a mountain of a man, same height as me, but just massive, telling me that he's lost strength just handling luggage, was hard for him. Anhedonia, lack of pleasure. There's this kind of blandness that overtakes them, where they're just going through the motions, no joy, no passion, as I have over in the next column. Hard to focus, really hard to complete a neuropsych exam, by the way. I really counsel attorneys to not get neuropsych on these people if I suspect growth hormone deficiency, because they fatigue so badly that their testing ends up being invalid, and you certainly don't want that to happen, because it's mana for the other side, who's trying to make a case that it's anything but a brain injury. temperature intolerance, decreased libido. All right, my guy yesterday, he and his wife said 3 times a week prior to the injury. Last time they did it 5 months ago. And that was just trying. He just wanted to try. Emotional negativity, absence of joy, mild paranoia. I used to see this in the NFL guys, but they were mildly paranoid. And I should also add suicidal. Suicidality was a major element of what I observed in the former NFL players. Passive. Now they didn't necessarily take action, but they would have the thought of suicide popping into their head while driving over a bridge, for instance, or at other times. Insomnia, yeah, sleep. Initiation of sleep requires growth hormone releasing hormone to be pulsed at about 8 o'clock at night. And consequently, I believe that when the hypothalamus is involved, we see fairly significant insomnia. Sometimes you see hypersomnia, where people are tired all the time. They sleep 12 to 14 hours a day, getting up to eat and go to the bathroom. Okay, let's keep going. Hopefully you have a good idea. This is, in summary, this is not a pleasant problem to have. If you have these symptoms, and God knows I have many patients that I've treated over the years, over 500, that have this syndrome, it is really unpleasant. On the other hand, it is really gratifying for me to be able to put these people on growth hormone, or maybe additionally testosterone, and watch them get their lives back, right? And I think you probably want to be part of that too. It's one of the most gratifying things I've done in my life, let alone my career. So what about the causes, right? So,
Dr. Benson,
yeah,
we've had several really good questions coming
okay.
from viewers. One of them is asking, are there blood tests that will detect pituitary gland injury? And then a follow-up asking, what kinds of providers are going to offer hormone testing? Is that an endocrinologist, a neurologist, or someone else?
All right, let me start with the second question. It is an endocrinologist. I am going to talk about the testing. All right, so just hold on, be patient. That's coming. Okay, so let's talk about what the possible causes of growth hormone deficiency are in adults. Because there are other causes, but they're easy to rule out. All right, trauma. Let's put trauma up there. It's probably the most common. Aneurysm rupture, particularly uh, aneurysms in the area of the sella, where the pituitary is. So there are arteries that are in that area, and so sometimes we do see aneurysms rupture, but again, easy to rule out, right? Somebody has an aneurysm rupture, it's typically not something subtle. You can see it on imaging. Central nervous system infection, okay? So we're talking about encephalitis. We're talking maybe about a severe meningitis. Easy to rule out. Tumors. All right, so tumors of the hypothalamus or pituitary. Here's a list of some of them. You can rule those out with imaging. Infiltrative granulomatous. So here we're talking about connective tissue, inflammatory diseases. Usually people come with a history of this. And it's something certainly with contrast that you can see on imaging. Irradiation. So similar to having tumors in that area, if you've been irradiated in that area for a tumor, that could potentially cause it. Surgery, right? Obviously, surgery involving those tissues. stroke. As you can see, these things are usually readily available through history. People can tell you whether they've had these issues or not, and a good clinician can certainly sort through the differential diagnosis. But most importantly, the timing is everything, right? When did the symptoms ensue? If they came on, shortly after the injury, now, of course, people are dealing with all kinds of pain issues and other symptoms that may obscure these other symptoms, right? People have fatigue for reasons after trauma other than hormone. But I always say, let the dust settle, right? After a few months, 6 months or so, a lot of those other issues, kind of subside, and people should generally get better. But that's when you start to sort of say to yourself, whoa, there is something going on here. Okay, evaluation. Okay, so the guideline from 2005 said screen all moderate and severe TBIs or anybody with symptoms suggestive of hypopituitarism. Well, I can tell you that most docs aren't even screening moderates and severes, right? So that means that a lot of people are missed, and of course the milds. What I'm trying to sort of motivate here is that it's just not on people's radar, and it should be, because look, in 2005, the endocrinologists published their own guidelines saying do this. But I'm here to tell you that most of our clients and patients don't get to endocrinologists. So of course, the endos can't do what they might do. All right, so here's some screening labs. The most important are IGF-1 for growth hormone. But to really test growth hormone deficiency, if you suspect it, you have to do what's called provocative testing. And what that means is you're giving an agent intravenously to stimulate the pituitary to release as much growth hormone as it can. Now, there are a number of agents that have been used over the years. Insulin, meaning the induction of hypoglycemia, is the strongest and most reliable test to diagnose growth hormone deficiency. Glucagon is probably number 2, but it's certainly not as reliable. It hasn't been in our hands, not as reliable as the insulin tolerance test, it's called. The others I'm not going to talk about because they're really not done anymore or not reliable. Deficiency, to make a diagnosis of deficiency means that and you're sampling growth hormone every half hour to 45 minutes. If none of those samples get up to 5 nanograms per deciliter, you've got somebody with deficiency. Severe is defined as 3 nanograms per deciliter. Contraindications: you're not going to induce hypoglycemia in everybody, right? So old people, probably not, although 60 is borderline. I take that personally. Coronary heart disease, right? Somebody with a bad heart, you don't want to drop their blood sugar. Somebody with epilepsy, you could induce a seizure. And then somebody with a history of panhypopituitarism could really crash if you drop their blood sugar. Okay.
Have we reached a good point for a little break right now?
We have.
Okay, fantastic. And Dr. Benson, is it okay that I close out of your slides just for a moment?
Sure. Yeah.
And what we're going to do is just take a very quick break, you guys, because I've got some amazing people that I want to introduce you to. And the first one I'd like to bring in is Taylor with HMR because he's going to tell you guys some about the great things they do over there. And Taylor, we're excited to see you with us today.
Thank you, as always, Ginger, for the great introduction. I know we have to speak pretty quickly today. It looks like I'm leading off the Three Stooges here for the sponsors. So again, my name is Taylor Luce with HMR. I'm the Southeastern Regional Manager. Been in the space about 11 years. HMR has been helping injured plaintiffs for about 15 years. And what we do, on a larger scale, a lot of you guys are familiar with our medical funding from, your most basic single study MRI to a catastrophic brain injury. As Dr. Benson's talking about, we fund those. So your law firm, you don't have to put that strain on your line of credit. But a lot of these folks can't provide for their families. Whether it's routine groceries, gas, car payments, medical bills that, they don't want to pay out of pocket for. We offer pre-settlement advances as well. And then to holistically bring everything together and bundle everything up at the end, we offer our case costs and expert funding to pay for your accident reconstructionist, to pay for Dr. Benson to come testify live at trial, to pay for these demonstrative aids that Cody at Fox AE provides and stuff like that. We're paying for all of this so you guys don't have to. And the old adage, and I know it seems cliche, but why use your own money if you could use HMR? So, we do look like we do try to treat every case, obviously, individually, that every case is unique and that, we want to be that, full service provider for you guys, whether it's medical, pre-settlement, or case costs and expert funding. And I do believe if you give us a chance, you will not be disappointed, and we can truly help change the trajectory of your case and help prove your damage model. So thanks, everyone.
And also, Taylor, I just wanted to thank you guys so much for everything that you do at HMR. I know that you guys will be coming with us at our next live seminar, which is going to be in the Fort Worth Stockyards, about 30 minutes outside of Dallas, Texas. And we're going back November 6th through the 8th for our depositions, our trial seminar. It is already almost sold out. So if you're trying to come to this program, it is one of our absolute favorites. Please go ahead and look at connectionology.com to find out the agenda and look at the details and go ahead and hurry to get registered. But you guys have been amazing supporters along the way. Highly suggest that everybody reach out to you. And if you could just please put your information in the chat box for everybody.
Thanks as always, Ginger. See you guys soon.
And also stay tuned because the coffee giveaway is coming up at the end of the webinar today. So you do not want to miss it for your chance to win some amazing coffee. Thanks, Taylor.
All right. Thank you.
And I see that Sam is also here with us today, coming in. Sam, I'm not sure if you're traveling, if you're in Atlanta, Georgia today.
I'm actually in Chicago. I saw John. We were at the Big Truck and Auto Summit here.
I am a little jealous. I'm hearing everybody is there right now, except for me. But anyway, we're so excited that you're popping in today. Again, you guys have another company, your dad, Paul. Stratejic is a company that you guys help find those ex-employees, and you're able to these witness, these locating service basically where you can find people that nobody would even imagine you could find, and it literally will change somebody's case. So I'm not going to give it all away because I get so excited, but talk about the ill reports too, okay?
Yeah. Well, thanks, Ginger. It's always good to be on Connectionology and love this community that we've built. Our company is Strategic Relationships. I'm sure you've seen us around. We are the ex-employee guys. If you see us at a conference now, we've got these backpacks that say ex-employee experts, stuff like that. But what we do is we help track down former employees of your defendants. And what that means is you come to me, you say, hey, Sam, I'm suing this company. I am looking for people who held X, Y, and Z job titles from the years 2015 and 2018. And what we do is we get you a list of people that meet that criteria. And the idea is we take all those folks, we distill that list down into the prime time folks through interviewing, and we learn from them the inside story about your case. So we work on all kinds of cases, really anything you can imagine outside of an MVA. What we do is we learn more about policies and procedures, hiring practices, insider stuff that maybe could go as far up as smoking gun kind of situations that really could, without a doubt, be the game changer in your case. So if you got a high damages case, you think it might make sense to kind of check in with us, see if it makes sense. It is free to call me. I won't charge you anything for my time. We can talk about it and we can see if we could add value to your case. So yeah, I'll put my stuff in the chat. Call me anytime. And if I don't get the first ring, I'll call you back. So
Perfect. Well, Sam, thank you so much for being here with us. You and Taylor and our upcoming speaker, Patrick, I would have all of you guys on, well, actually do, I have you on speed dial. So keep up the great work and continuing to help all of your attorneys and your clients around the country. And thank you so much for everything that you do. Looks like there are some people waiting for your information in the chat box. So be back here again soon, okay?
all right, thank you.
And last but not least, I am really excited that I see that Patrick is coming in today with OnPoint Legal Nurse Consulting, but he's got this beautiful lady with him, Miss Sarah, and I am so excited to see her smiling face. I usually see both of these two amazing people at all of our live seminars, but Patrick, he's spoken on a lot of them as well. He's been a nurse for over 21 years, and he's going to share with you guys some of the most important things that OnPoint can help you out with. But it is an honor to have both of you here with us.
Well, thank you, Ginger, as always. Carolyn, wonderful to see you, Dr. Benson. Wonderful presentation, as always. So like Ginger said, my name is Patrick. I've been a nurse for 21 years, and I'm one of the directors over at OnPoint Legal Nurse Consultant and Expert Witness. So what we do over here, a lot of the individuals that are online today have used us, so thank you very much. We're a litigation support company, so we help from intake all the way through trial with placing experts, record retrieval, organization. Our experts are either nursing experts like myself, medical experts, and then specialty experts like engineers, things like that. So we have a large database of vetted experts that we can help with your cases. We do have a couple of special reports that we always like to tell you guys about, especially for this topic. We have a pain and suffering report, which is a non-economic damage report that helps paint a different picture. It's not just a legal picture of what happened to these individuals that were injured and post-injury, of things that they enjoyed prior to the injury, and then how things have been affected based off of the injury. So I'll put my information in there as always. You guys have heard me talk a million times, so that's why I brought Sarah to spice up everything. She's going to introduce everyone to a new product that we are rolling out at OnPoint.
Thank you, Patrick. Hi, everyone. Hi, Ginger. Nice to see you, as always. And shout out to some of the attorneys that are out there. I know I've worked with a couple of you, and it's been a pleasure. So hello, you know who you are. It's Sarah. So yeah, I'm here. I want to talk about our new marketing campaign. It is called One Case. And so it's pretty simple. Try us out for one case. And one case is really all that you need to really determine that OnPoint really is the company for you. We're easy to work with. Our reports are amazing. Our specialists and nursing experts are amazing. And we offer the full suite of services. With our new campaign that we have, you can get up to $225 in sort of free services, and that will include record retrieval or record organization if you will try us out for a case. If you've tried us out for a case before, that doesn't matter. You can just send us another case our way, and that's fine too. So we're happy to work with anyone and have you take advantage of our new offer that we're having. And so yeah, Patrick's going to put our information in the chat, and Ginger might be kind enough to send out our one case flyer to you guys in the email. And thank you. Thank you so much for your time.
I'm so glad that you did bring that up, Sarah, because after webinars, I always email everybody the contact information so you can reach out to our speakers, to our amazing partners. But if you open up that file, you've got a brochure on each of your companies, and it's just a great kind of like a checklist. You can kind of look and see everything that you guys can help people out with. So, but always go to the website too, because there's great information on there. But it's great to see you guys. We'll see you back here again soon, and keep up the great work too, okay?
All right. Thanks, Ginger. Bye, everyone.
Dr. Benson, do you remember playing bowling with Patrick in Idaho?
Oh, yeah, that's right.
We all had a great time. We were just at our fourth
We're never
annual
supposed to talk
TBI.
about that, Ginger.
Yes, our fourth annual TBI seminar. We were just in Sun Valley, but get ready, guys, because our fifth annual TBI seminar is coming back to Sun Valley. We're going April 20th through the 24th, And I will be putting those details on the website so you can attend that live in person. That's a seminar you just don't want to miss, because you actually get to spend one-on-one time with people like Dr. Benson in an environment where you get to ask questions, that you never would normally get a chance to ask, because like I said, Dr. Benson, he's busy, but we get him one-on-one in Idaho, and then you get a chance to bowl against him. So, all right,
Well,
guys.
it's a good thing I earn my living doing brain injury and not bowling. That's all I can say. And don't
Well,
say anything, Patrick, because you saw
we're
the
having
way
a
I
rematch.
started. It was
I'll never say
embarrassing.
anything, Dr. Benson.
And here I was trying to show off for Ginger too.
It's a
All
good
right,
thing you're a
guys.
nurse, yes.
Well, thank you again for everything that you do. And then Dr. Benson, if you like, we can go ahead and open your slides and we will finish where we left off. And then I wanted to let everybody know, stay with us today, because we're going to go to at least about 5 o'clock. So you still have time to get in all of your questions for him as well.
And speaking about medical record reviews, we had a really great question from one of the viewers. How would a TBI impact someone with pre-existing psychiatric issues, such as someone who already had depression, anxiety, PTSD, bipolar before they suffered a TBI?
Yeah, great question. And I did see that in the chat. Brain injury doesn't make too many things better, but it certainly can exacerbate all of these symptoms. So, we know that's true. It's in the literature. We cite that all the time. And when the other side says, no, it's all this pre-existing stuff, we know how to combat that. And it's not hard. And usually it's not only the psychiatric or psychological symptoms that we see. So, it's really, it's just, the collective of all the symptoms and then the objective stuff that we find. Are we good to go? Okay, here we go. Let's see. Can you see that, Caroline?
Yes, I can see
Okay,
that.
all right. So now finally we're we're going to talk about how you treat this condition, because I really want you to derive, the same satisfaction that I do. It's one of those things in life where it gets you up in the morning, and it keeps you going. And when you put your head on the pillow at night, you feel like you've done something meaningful. It doesn't matter whether you're a doctor or a lawyer. If you are part of the solution, it is just a wonderful thing. So replacement therapy it's easy. The hard part is making sure that you get the other side to pay for it. So what's the treatment? Once daily injection of recombinant human growth hormone, or HGH. It's manufactured by, probably about 10 different pharmaceutical companies. The injection is not into the muscle, it's just below the skin. So it's really easy. Typically, it comes in a preloaded cartridge pen, similar to an insulin pen. Easiest thing in the world. The injection is to the lower abdomen. Range is typically 0.2 milligrams to 1 milligrams daily. This is something that the endocrinologist, and I did see a question, the endocrinologist that I have used for 10 years now, who I only work with because frankly, there aren't that many endocrinologists, adult endos, that will do the testing. And I'm trying to make it my business now to shake things up at the Endocrine Society, because they just simply do not realize the prevalence of this problem and the impact of treatment. So that's why I'm on the warpath now. Okay, so typically the endo, after diagnosing and starting treatment, will follow up with the patient every 3 months. Doesn't have to be in person. In fact, Dr. Al-Zahili, the endocrinologist that I'm speaking of, will do a telemedicine every 3 months. Patient will have a little blood test done called an IGF-1 the week preceding the telemedicine visit, so that he knows roughly where the growth hormone level is. It's a surrogate marker. It's not as good as doing the growth hormone stim test, but you can't do that every 3 months on somebody. So you rely on symptoms and the IGF-1. Early studies reporting treatment effects in growth hormone deficiency caused by, okay. So if you're interested, there are really a lot more studies now showing the effectiveness of growth hormone. I want to just show you one of the early studies that I think is really compelling. So it compared growth hormone treatment, a cohort of growth hormone treated people and a cohort of practice or placebo in rehab. And what was being measured were cognitive measures: attention, memory, executive function. Exactly the cognitive functions that people complain of and that are affected by a tired, cranky brain that shuts down after 30 seconds or so. And you can see that there was significant differences between these two groups at 1 month, and that difference actually increased over treatment. This is exactly what I see. People within 2 weeks tell me that they're sleeping better and the fog is lifting. And by 6 months, it's quite noticeable. But I've got people who are years out who tell me that they're continuing to improve. Okay. A colleague of mine in Galveston, University of Texas, Galveston, Brent Maisel, and Randy Urban was the endocrinologist, performed a very high quality study where they looked at brain changes, structural brain changes, functional brain changes using functional MRI, and looking at behavior in people with growth hormone deficiency that they treated. And they found, I don't want to go into the details, but they found that there were significant differences between treated and untreated people. So what that says is that growth hormone is changing the brain for the better. And of course, not surprisingly, that's why people are improving. Okay. We published a study last year that identified the key symptoms that distinguish between brain injured patients with growth hormone deficiency and without growth hormone deficiency. So we developed a screen called the QOLS-99 that we can provide to you at no cost, and it should help you, because what we found, what we found was that the sensitivity was upwards of 80%, and the specificity was also good. And so what it does is it instead of sending everybody for testing as a screening test, it will tell you who is likely to have this syndrome. And of course, that makes it much more efficient, and gives you better value if you're going to send somebody off for testing. So to summarize, on the pituitary end, there's a wide, wide range in the literature in terms of the prevalence of this problem, but more studies that follow people over time seem to show that at 1 year, about 30% of people with brain injury have this, and they're not going to improve. They're not going to get better at 1 year. It again doesn't correlate well with severity, meaning that you're just as likely with milds as you are severes to have this. Repetitive obviously is worse, tends to present in the first year, not later. It's not a remote complication. Isolated, and especially growth hormone deficiency, is 2 to 3 times more common than having multiple hormone deficiencies after head trauma and the treatment we just discussed. Okay, now let's move on. Any quick questions, Caroline? We want to bang out a couple?
Sure. So how about the testing? You had a question about EEG and ERP testing. Is that something that can be used? And how should lawyers get their clients to who they need to see? One of the general questions is, if you think your client may have a traumatic brain injury, who do you need to send them to?
Well, the easy answer is me. Okay, right. So let me tell you how that goes. If you send your client to me, I will spend 3 to 4 hours with your client doing a very detailed examination, including a deep dive on the cognitive evaluation. At the same time that they're seeing me, or the same visit, they will undergo this MRI, which includes DTI, which I've described, but it also includes a volumetric scan, which is really sensitive, particularly in chronic cases, because it will show atrophy. It will reveal areas of brain that have lost neurons, that have lost axons or brain substance. So that, combined with the DTI, I believe makes our MRI extremely sensitive. So we do this as at a flat rate, as a package. I think it's about 12,000 for both the evaluation and the imaging. The imaging requires a lot of offline processing, but you get reports of both. And typically I have a real good idea of what's going on with the case, and we can do a phone call and discuss next steps. For instance, if we think that they should undergo pituitary testing, if they should undergo vision testing, inner ear testing. So that's kind of the way things go. In terms of EEG and ERP, they're not that useful. I don't know that they've really even met muster. Not that some courts don't allow that stuff in court. I just, my reading of the literature, and certainly in my clinic, we did something called QEEG, or quantitative EEG. I'm just not impressed with its ability to detect milds, particularly in the context of growth hormone deficiency, which slows the brain down. So that would be my answer to that. Anything else, Caroline?
Would you see patients that have already had DTI done somewhere else?
Do I see that? Is that the question?
Correct. If someone had a patient that already had the DTI done somewhere else, would you be able to treat that patient, or would you have to redo the DTI on your own?
Well, it kind of depends. Just like most things, quality and flavor can vary depending on who's doing the testing. If the particular lab has not used controls, and they're simply just sort of cherry picking regions of the brain on that individual's brain, I don't find that to be useful. But I'll be straight up and I'll tell you whether I think it's reliable and whether I can use it or not. Okay.
Thank you.
Okay. So let's talk about this this strange thing called binocular visual dysfunction or vision dysfunction. Turns out about 30% of chronic mild TBI patients have it. I'd say for the patients that I see, it's more like 90%. And if they don't have this, I'm questioning the diagnosis of TBI. That's how sensitive this is. If they have not recovered after the first 3 months, then it's a good idea. If they haven't recovered from their TBI after 3 months, it's a good idea to screen for binocular visual dysfunction. Well, I'll talk about what it is in a second. The screen involves a questionnaire that one of my colleagues developed. Her name is Debbie Feinberg. She's a neurovisual optometrist in Bloomfield Hills, Michigan. I worked with her for over 10 years. And she's really nailed this down. So this questionnaire, well, I guess I'm not going to go into the questionnaire very much. That's okay. Would take too long. But the questionnaire has just a range of different potential symptoms on it, everything from dizziness to double vision to hypersensitivity to light, neck pain, headaches, anxiety, because all of these are symptoms of this condition. When your eyes aren't behaving, when they're not playing well as a team, it's very disorienting. And there are just really a plethora of symptoms that you see with this. I diagnose this virtually every person that I see with a brain injury. And I can do it at the bedside. I know that we can treat them and really mitigate or eliminate these symptoms. Okay, so two of the most common causes or types of binocular visual dysfunction are something called vertical heterophoria, which basically means the eyes are misaligned in the vertical plane, and something called superior oblique palsy, which is very similar. It's kind of hard to differentiate. The difference is with superior oblique palsy, it's one nerve, the fourth nerve, that was let's say that was injured, and that leads to some misalignment of the eyes. So the eyes don't like to be misaligned, but in reality, we all have asymmetries. We're born with asymmetries, but the brain knows that, and it basically wrote a little script to correct for that misalignment. But after these brain injuries, the brain just doesn't seem to do as good a job with that compensation. Okay, yeah. So the brain responds to this uneven image and impending diplopia, meaning double vision, by overusing, and the emphasis is really on overusing the muscles that move the eyeballs. So if the brain can't fix the problem, then the eye muscles are trying to get things right, and they fatigue. They fatigue, and then what people report, just like yesterday, they have pain around their eyes, pain of their forehead, pain of their temporalis area, and they call them headaches, and their docs call them headaches. And yeah, it is head pain, but it's not because of nerve damage, and it's not because of migraines. So The resulting strain and fatigue of the extraocular muscles causes symptoms of headaches, feeling of being disoriented, lightheaded or dizzy, anxiety, and visual and reading difficulty. So here's just a quick view of what these eye muscles are, like the lateral rectus, the inferior oblique, etc. They move the eyeball, and they're small. Head tilt. So one of the tells of this syndrome is that somebody comes in and they tilt their head, and they just stay that way, and they're not aware of it. But what's happening is that the brain is trying to align the eyes, and it's doing so by tilting the head, which can cause neck issues after a while, as you might imagine. So what are some recurrent themes for these patients? What have they experienced? Well, their symptoms go unrecognized as the true etiology that they are. So docs are treating, headache symptoms. They're treating anxiety with anti-anxiety medications. They're treating the nausea and the dizziness with medications. Us docs are really good at pulling out our pens on our prescription pad and writing scripts. It's the easiest thing in the world. You send somebody out the door, they're happy because you did something, and you don't have to deal with the aftermath. Unfortunately, sometimes the aftermath is not a good aftermath, symptomatic for a long time. So these people tend to endure these symptoms because there aren't a whole lot of docs that really understand it and know what to do about it. So I see, most of the people I see, I will send to a neurovisual optometrist, and I'm seeing people sometimes after 2 or 3 years post-injury, and I love it, right? Because I know I'm going to be able to help the person. I feel bad for them because they've gone 2, 3, 5 years without treatment. That actually happened, 5 years on a young female patient that I saw a few months ago. And they're seen by many different care providers, and they're not getting better. They have a lot of tests being performed, many medications tried, many procedures performed. Okay, you get the idea. They never improve. How about this questionnaire? Well, there's an adult version and there's a pediatric version. They're the most powerful, consistent tools to identify these people. If your score is above 15 on this symptom questionnaire, there's a good likelihood you have this. Score of greater than 40 correlates with significant disability. Now, what's the treatment? Well, the treatment is either vision therapy, which can be pretty onerous. Typically, people go to a therapist 2-3 times a week for up to a year, sometimes more. Oftentimes, they don't improve that much and they drop out. Prism lenses is really an immediate fix. It's not only does it help with treatment, but if somebody responds to the prism in the office that same day as the examination, you pretty much have your diagnosis firmed up. So it allows for weaning medications, enables patients to participate more effectively in their cognitive therapies. So you might imagine that these people have multiple problems going on, including cognitive issues that they're going to a speech pathologist or an occupational therapist for. If their eyes if they have this issue, then watching things moving on a page or having their eyes scrolling, and this is a common symptom, is people can't stay on their computer, they can't stay on their phones because their eyes are moving over the text. It's the same thing as trying to track a moving object. Those are the triggers for symptoms. But I have people that from the time they wake up to the time they go to bed, they have a headache and they don't feel right. All right, this is what this makeshift these trial prisms look like. This is what they put on after they've been examined, and the optician dials in a prism prescription. They walk around, they do things, and they report their symptoms pre and post prism challenge. And I've looked at enough of these and heard a lot of stories from patients about how they walk differently, and everything changes, and it's really fun for me, fun for them. Results of treatment: average of 70% reduction in symptoms within 20 to 30 minutes of applying the prisms. Can't beat that with a stick. 80% by the end of treatment, right? So end of treatment might mean after a year and a couple of adjustments. Conclusions: symptoms of BVD are frequent, not being recognized as being visual in etiology despite extensive testing and consultation by other treaters. BVD appears to be causing post-concussive symptoms in 30% of TBI patients. Sound familiar? Wow. Well, how many times do I see people with pituitary and vision? All the time. Same person. Very common. TBI appears to be causing the BVD. Okay. All right. Now, let's move on to the ear. Inner ear anatomy. Okay. You need to memorize this. No, you don't. All right. So, here's the outer ear. Here's the external ear, the external auditory meatus. Here's the eardrum. Here are these bony ossicles, like the malleus, the incus, the stapes, right? And then you've got this structure right here, which is comprised of the vestibular apparatus and the cochlea, which is auditory. All right, now we're going to focus just on the part of the inner ear that senses movement. That's the vestibular system. We've got the semicircular canals, which are oriented perpendicular to each other, as you can see. So they're really sensing movement in all three planes of movement in 3D. And you've got your vestibule comprised of the utricle and the saccule, and these contain cells that are sensitive to movement, either horizontally or vertically in relation to gravity. All right, so here's kind of a schematic of the vestibular apparatus. Semicircular canals, utricle, saccule, ganglion, sends neurons to the brainstem, either directly or indirectly to the cerebellum. The midline of the cerebellum is a vestibular extension. Okay, so what kind of injuries can you get? What do they look like? So from trauma, you get a labyrinthine concussion. You've probably heard of benign positional vertigo or benign paroxysmal positional vertigo. There are fistulas. There's something called semicircular canal dehiscence. We're going to talk about each of these. Labyrinthine concussion, a jarring injury to these fluid-filled ducts and chambers of the inner ear can cause balance issues. Common result of head trauma. All right. Benign positional vertigo, what's happening here is you have these otoliths, these little stones, these calcium crystals that break loose from the vestibule and make their way into the semicircular canals, and that causes vertigo. And we'll get to these. So vestibular motion detection, otolithic organs detect linear movement, sacral is vertical, utricle is horizontal, semicircular canal detects angular or rotational movement. Okay, this is kind of cool. So now we're looking at the sensors to gravity and horizontal movement. And it's kind of cool the way nature structured this. So you have these otoliths, these little these little calcium stones up here. You have this gelatinous membrane here, and then you have these hair cells, which are really the receptors. So what happens is you got gravity, and the head tilts. What happens? Well, because of the inertia and the weight of these stones, it moves this gelatinous otolithic membrane, causing these hair cells to bend. When these hair cells bend, they send impulses to the vestibular nerve. Okay, so that's how this works. So how about this labyrinthine concussion? Well, you don't, the reason it's called a concussion is there's no temporal bone fracture. So there's nothing obvious to explain the symptoms. The pathology is all over the place. Inner ear hemorrhage, nerve getting pulled and causing a shear injury, a fluid pressure wave causing problems, or even vasomotor, meaning could be a vascular cause. Most recover within weeks or months. Okay, so that's the important thing, is that the labyrinthine concussion, right, similar to a brain concussion, things tend to get better. All right, now how about this cool thing called BPPV, right? So we got these stones here in the vestibule, right? And then there's trauma, and now these stones are down in the semicircular canals, or this canal, which is probably the superior semicircular canal. So this is going to sort of mess with this canal's ability to transduce angular movement. So when the person moves their head, they get dizzy, they get vertiginous. Okay, and then you can have a fistula, which is essentially a tear and then a fluid-filled space between the external ear and the middle ear. And then possibly the most interesting one is this so-called third window syndrome. So you have your oval window and your round window, but with trauma, and particularly with congenitally thin temporal bone overlying the canal, that canal can be in communication with the middle temporal fossa, and thereby pressure waves can aberrantly distort the perception of angular movement for this particular canal. So this is called third window syndrome, since this is a window that should not be present. And what that leads to is that the vestibular system, or the ability to perceive and and really to compensate for angular movement of the head, it's now getting abnormal sensory information that it should be closed off to. So the system is open, it should have been closed. So even sound can cause vertigo, and that's sort of the one of the signature symptoms and signs of third window syndrome is that loud noises can actually induce dizziness. Some other symptoms: sensitivity to sound, hearing noises in your head, like your heartbeat when you put your head on a pillow that you normally would not hear. Tullio's phenomenon is what is the term for this sound-induced vertigo. It's really cool when you have a patient that reports that. Oscillopsia, here's another one: when stationary objects appear to move. So, I'll ask my patients, when you look on the horizon, and you see, cars or a sign or whatever it is, do those things appear to be, moving to you? And if they say yes, yeah, they appear to be sort of moving back and forth, that's oscillopsia, and that can be an indication of this dehiscence syndrome. Let's see, activities that change the pressure. Okay, this is important because a lot of times what we see, and this is important, I think, for the attorneys out there, is that the patient doesn't necessarily have the full-blown syndrome right off the bat after their injury. Part of it is that they're not doing much. They're laying low because they have lots of symptoms that, require them to rest. Now they start doing things again, and I had a patient who, went out and started chopping wood, about a week after their injury. And man, did they get worse. So what I'm here to tell you is that this third window syndrome definitely can be exacerbated by what we call Valsalva maneuvers. In other words, these where you're lifting a heavy object, or you're straining, coughing, and that can really exacerbate that third window, that gap. And so again, it's another cause of symptom exacerbation, or even new symptoms developing over time, when the other side is trying to say, hey, that's not the way brain injury works. Well, that's probably not the way brain injury works, at least most of the time. But when it's an inner ear problem, it might be the rule and not the exception. Okay. So when people have these symptoms, they're really in distress. It can affect their cognitive functioning, certainly their psychological functioning. Okay. All right, let's move on now. We're getting close to post-traumatic dysautonomia. Okay, probably something you haven't heard about before. It's dysregulation of the autonomic nervous system. You may have heard of the autonomic nervous system. This is sort of your unconscious nervous system that keeps you alive. So it controls involuntary body functions like heart rate, breathing, digestion, these things that you don't think about, that are really important. What are the symptoms of dysautonomia? Well, can be cardiovascular, heart rate fluctuations, tachycardia, bradycardia, low blood pressure, fainting. I just did a supplement on a patient that I recently diagnosed, or who was recently diagnosed with this POTS syndrome, young person, and it really sort of explains a lot. I really wasn't on the POTS initially with her because she also had growth hormone deficiency and binocular visual dysfunction. But but she didn't really respond well to treatment. And I think we can explain it by the fact that she can't really stand up for very long before she has to lay back down again. Temperature regulation, flushing, sweating, feeling too hot or cold, GI symptoms, headaches, probably related to blood flow abnormalities, muscle tension, fatigue, dizziness, mood swings, lots of what we might call non-specific symptoms. I mean, how often have I mentioned fatigue today? Well, this is another cause of fatigue, and it certainly was in this young patient. And so she didn't necessarily derive the benefit from growth hormone because she had another cause of her fatigue. So then there's a type of autonomic or dysautonomia called POTS, postural orthostatic tachycardia. This is what you most commonly see with trauma, a form of dysautonomia that specifically affects heart rate and blood pressure regulation. So you'll see heart rate elevation, blood pressure will go down, what we call orthostatic hypotension. When you stand up, your blood pressure needs to increase or you will go down. It's been linked to physical trauma involving head, neck, and spine. Mechanisms include injury to the amygdala of the brain, prefrontal cortex, brainstem, inflammation, including induced autoimmune activation, risk factors. Females are at a higher risk for this, diabetics who have neuropathy, connective tissue disorders like Ehlers-Danlos syndrome. I've seen it a few times with these hypermobility syndromes in women, in females. Okay, treatment, symptomatic. There's no great treatment. You might try midodrine and salt loading to get their blood pressure up so that they don't pass out all the time. Okay, let's see. Now we've got, this should be post-traumatic stress disorder. Now, what I want to say about this is that this is really a bastardized diagnosis. Lots of people get diagnosed with PTSD that don't have PTSD. PTSD is very specific. It includes intrusive thoughts, nightmares, flashbacks of the traumatic event. Now, many of my patients don't even have recall of the traumatic event. So for them to have flashbacks of something that their brain never encoded in the first place is a little bit far-fetched. But, as I always say, don't let the truth get in the way of a good story, right? So really, treaters on both sides will incorrectly make this diagnosis, when in fact, it may be binocular visual dysfunction with anxiety, it may be pituitary dysfunction, or it may just be their brain injury with increased anxiety. Because as I always say, emotions don't live in the heart, they live in the brain. Avoidance. So, with PTSD, people avoid associations with the traumatic event. They won't go on they'll avoid the intersection where the accident occurred. They'll avoid or not look at black cars because they got hit by a black car. Changes in thinking and mood. Well, yeah, you can see cognitive issues, certainly emotional issues, depression, anxiety, change in arousal and reactivity, irritability, angry outbursts, right? This has to do with sort of the chronic fight or flight state that these people are in, hypervigilance. And what we know from the literature is that this takes a toll on the brain. We know that these people tend to have higher than normal levels of cortisol, which is a stress hormone. And that cortisol has effects on the hippocampus, and other limbic structures, so that we see atrophy, we see actual cellular death that at times we can diagnose using volumetric imaging, which is very high resolution. And that can be another objective indicator. And I know there was somebody that wanted me to talk more about imaging. I really can't. I've covered a whole lot today, but I do want to at least show this slide. I've been showing this slide probably for about 15 years now. All of these images were acquired in the same subject. So it goes to show you that MRI is a very versatile platform. It's a one-stop shop. If we want just structure, we can get beautiful structure from MRI. But if we're looking for hemorrhage, we can do an iron-sensitive sequence, and we can see this person has a thalamic hemorrhage right here that you can't see on plain structural imaging. It's a T2 weighted scan. We can look at blood flow. We can look at fractional anisotropy. This is DTI we're looking at right here. And when we compare our patient or your client to a set of normals, we can determine where in the white matter there's damage by virtue of water flow being altered in these areas. And we can also do a little bit more colorful types of renderings of DTI and tractography. And actually, we just released a type of image called correlational tractography, where we identify tracts that are damaged compared with controls. Instead of looking at individual voxels, now we can look at tracts and create some nice images as well. Or functional MRI. As Caroline mentioned, I cut my teeth a long time ago in the 90s doing functional MRI, where we can activate different regions of the brain simply by having somebody perform a task. And then there's something called spectroscopy, which allows us to look at the metabolism and the neurotransmitters of different cellular regions of the brain. Okay, so let me finish with giving you the more full contact information. Our business office is in St. Petersburg. We recently moved our business office from Boca Raton to St. Petersburg, which is just down the street from me. When you have a case that you want to discuss with me, this is the number to call. Speak with Brent. I mentioned he's been with me for about 15 years now. That's his email. You certainly can email him. He'd probably prefer that. And our clinical office, where I will see your client, is very close to the business office, just a few minutes away in Pinellas Park, where I have a nice office suite. And I should mention that next couple of months, I expect that we will be doing the pituitary testing in Tampa in this clinical office. In fact, that's why I got this space, because my intention was to do growth hormone stimulation testing there. And we're just now in the process of training a nurse practitioner under my supervision and Dr. Asa Healy's supervision, so that we won't need to send your clients to Michigan. So with that, I'll stop. Take any questions.
Awesome. That was amazing, Dr. Benson. We have so many questions for you. One of the questions from the viewers is, what criteria do you use to diagnose a TBI? I have seen some use the DSM-5, whereas others prefer the Department of Defense criteria. Do you have a different approach?
Yeah, they're all basically the same. What the diagnosis of TBI historically has required is that there should be some alteration in neurologic sensorium. And by that, I mean that the patient either has amnesia or in some way they're altered. It can be just a subjective feeling of dissociation, disconnectedness. Sometimes it's pretty subtle, but these are criteria that do hold water. Now, with that being said, I will tell you that a lot of people that I see now have what I would call really mild brain injuries, and yet a year, 2 years later, they're really impaired. And what I'm trying to say is that you don't need a terribly significant brain injury to have pituitary injury or to have inner ear injury. That story I can tell you, just based on the last 5 years of seeing people, it just doesn't wash. So it does make it more difficult for us, to, in a sense, argue that somebody has a concussion or has a mild TBI. However, what I typically will say is that, I can't say the person doesn't have a mild brain injury. What I can say is that statistically speaking, we can't we can't exclude that possibility, but we also can't definitively say that they do, based on imaging.
All right, and we're going to take a quick break. Ginger will announce Nathaniel Murray, and then we'll get back to the questions and answers. So if anyone has more questions, please keep them coming.
Yeah, I'm so excited. We have one more coming in. We got Nathaniel coming in from Fox AE, who I think, Dr. Benson, you remember they do all those animations and graphics and demonstratives. And I think you met Cody when we were all in Idaho together. They do great work, and I know Cody's traveling today, so is Ryan. So we called in the next best thing. We've got Nathaniel coming in from Fox AE, who's going to share with you guys some of the great things that they do. And Nathaniel, thank you for jumping in. We're excited to have you with us.
Yeah, not a problem. Once again, thanks for having me, and good to see you again, Dr. Benson. So yeah, DTI stuff is what we're talking about today. So I wanted to share a quick animation. Oh, and I get it to share correctly. But if you guys do not know what we do, it's essentially we do animations, illustrations, whether it's medical, accident reconstruction, or just injuries. We do it all. And we love working with you and the clients to get something that will not only look great, but will also illustrate what happened, what they suffered through, and and show what the purpose is of the case. So in this particular animation, this is a DTI injury regarding a carbon monoxide. Is this coming in choppy to you?
Nope, we can see it.
Okay, perfect. This was a DTI injury where this particular patient had some carbon monoxide poisoning, and this was with Randy Rozek a couple years back. And so what we do is we show the actual DTI imaging. We show the injured area, and we take it from a rainbow, pretty colors, all happy, and we turn it into some yucky looking brain damages. And then we go slice by slice. And I'm not sure if you guys are seeing the jitteriness to it, but I think it's just my web browser that's doing that. Maybe it's smooth on your end. But we go through slice by slice, show all the injuries, and then we kind of do this ghosting effect so that you can look straight into the brain and see all those injured parts of the brain.
Yeah, it was moving a little bit, but it's so realistic though, Nathaniel. And I know everybody can also go to Fox Prime too, right?
Yes. Yeah, we've got a Prime website where you can essentially get ready to go demonstratives, illustrations, or even animations. We've got some spinal fusions, spinal injections, all sorts of stuff that you can just get right out of the box, one-time purchase for your particular case. And when the next case comes around, you just purchase it again. And if you have any questions about it, like if you needed something tweaked just a little bit, we can do that, just a little bit of an upcharge. But yeah, just give us a call, give us an email, shoot us an email, and we will discuss your case and we'll see what we can come up with you. And we like to fit your budget. I know some of the cases cannot do the full-blown animations just based on the case, but we also have some still shot options and some more budget-friendly options if you want to go that route too.
Love that. Well, thank you so much. John Romano and the entire law firm, Caroline, think the world of you guys too. Definitely one of the best in the entire country. So you guys keep, just doing a great job. And I've heard nothing but good things from all of our attorneys. So keep up that great work too. And we'll see you back here soon. But be sure to put your information in the chat box for everyone.
Yeah, will
And
do. Thank you.
please come back.
There was a question directed to you. Is there a ballpark figure for the animations?
Yeah, so we generally like to say 10 to 20 on the animations. Of course, that is some more in-depth animations. If it's a simple surgery, looking 5 or under probably. But just shoot us what you have, and then we will just shoot you a detailed quote or proposal based on your case. But 10 to 20 is what we generally say. Brain animations and stuff get a little bit higher. Our still shots start 1 to 3. And again, brain's more complex, so it's going to be a little bit higher than that.
Awesome. And that's why I always take people back. I'm like, go to Fox Prime because you could have everything you need on that website for like anywhere starting at $200. So
Yeah.
I guess, you kind of get what you pay for when it comes to this sort of thing too. And it also depends on the case. So thank you so much for being here, Nathaniel. And we'll see you back here soon. Okay.
Sounds good. Thank you.
And then Dr. Benson, I saw some more questions were coming in, but I want to announce the coffee winner right now because I can't wait another second. So Ted was not able to be here to do the announcement. However, he did send me the name of the winner, and I got so excited because I know this attorney, and he was actually with us in Idaho. And I don't know if you met him, and I promise this is not rigged. This is not planned. Ted gets a copy of, everybody who attends these webinars, and he puts it through his AI animation, and then it comes up with a few names that he sends to me. And then I look to see if they're watching. And if they're the first person on, they're the winner. So that's how it works. And I was so excited that our winner for the coffee giveaway is actually Mr. Lawrence Flick. So Lawrence, if you are watching, my Kansas City attorney, we're so happy that you won. You won 2 bags of this freshly roasted coffee, as well as an HMR coffee mug. And both Ted and I will make sure that you get this. But if you didn't win, guys, don't feel bad because there's going to be more chances next week as we have more webinars. So hang in there and don't give up if you didn't win. And Dr. Benson, if you haven't tried this coffee, you need to tell Ted so he can send you some.
Oh, good.
All right. Do you guys want to take, I think, that last question or so that came in, or what would you like to do?
Let me read the last question. Is there a composite score or index that integrates neurophysiological, neuropsychiatric, and cognitive assessments to predict the persistence of long-term symptoms following injury or insult?
The short answer is no, I'm not aware of that.
Understood. Right. And I think we addressed one of the other questions, which is it too late? Is it ever too late to get testing done? If a client hasn't had testing for 3 or 4 years, but they're still having symptoms, is it too late to get that testing done now?
No, it's never too late. And one of the beauties of the imaging is that really doesn't change that much after injury. So the DTI kind of stays around like a fossil. The SWI, the iron sensitive technique, stays pretty sensitive. There's not much iron that's lost over time, and the volumetric actually is more sensitive over time because volume loss is accelerated in people with brain injuries. So yeah, certainly from an imaging standpoint, it's never too late. And if your patient's still having symptoms, which, almost by definition they would be, then it's certainly worthwhile.
Do you have time for one last question?
Sure.
So have you had experience with right-left asymmetry? Have you testified on that? And do you see right-left asymmetry as resolving some of the problems associated with the use of a normative database?
Wow, boy, that's a loaded question since I published some of the early work using functional MRI to determine hemisphere dominance in language. That was all about right-left asymmetry. So the way we do our imaging is that we use norms. So inherently, we're taking into account any right-left asymmetry, as minor as it might be. But no, I don't specifically. I don't specifically look at asymmetry with DTI. On the other hand, I do with volumetric. So this sort of hinges on the idea that the right and left hemispheres structurally are pretty similar. But let's say, as was the case on a case that I just looked at yesterday, somebody has more right hemisphere damage than they have left hemisphere damage. And as a result, they've lost more brain substance in the right hemisphere compared with the left hemisphere. So because an asymmetry index is used statistically, we were able to say that that the difference between the right and left hemispheres globally and regionally exceeded that which would be expected in normals. In fact, it exceeded 2 standard deviations, which is significant. So yeah, we do take into account structurally asymmetry index.
All right, thank you. And I think those are all the questions for today. We've had several requests to have you come back on, so we're going to have to do that.
Oh, good. I would be happy to do that. And they're probably requesting that I talk about the imaging. Is that what you found, Caroline?
Yes, imaging definitely had a request to talk more about imaging, and I think just generally how the diagnosis works and what the lawyers should be doing, what they should be on the look for, and kind of the process.
Yeah, I mean, at this point, Ginger, I've probably got about 6 or 7 different lectures that you have. And I think we're probably covering pretty much everything that people are asking for. So we could just cycle through them again.
Dr. Benson, we've just not had enough, okay? There's a lot more that we're going to talk about. And you're right, there's some webinars if you go to our Connectionology YouTube channel. It's free, you can subscribe, and you could probably watch some of the past webinars that we've done with Dr. Benson, including this webinar, which I will be adding to our YouTube channel so you can refer back to it. But feel free to reach out to Brent, who can get you in touch with Dr. Benson if you have additional questions, and highly recommend that you guys just all stay in touch. But we love having you on here, Dr. Benson, and so does everyone else. We had lots of your friends watching today. In fact, I just saw that Rich and Mary Beth Haley, amazing attorneys out in Indianapolis, they were watching and said you were just cutting edge, love working with you. And then also we had the beautiful Ilya Lerma, amazing trial lawyer out of the West Coast, was with us today. And she said again, I was so happy to hear you and all the learnings that you've been teaching us.
Good. Ed, it looks like Melvin Belli. Is this the Melvin Belli?
Caesar is watching today, so he is here with us, and I'm still trying to get him to speak on a webinar. So Caesar, if you're watching, you need to contact me so we can make this happen. And John Romano insisted. But yeah, I can't thank enough everybody for watching, for all of your support. And please let us know if you have any questions. Keep an eye out on the website, connectionology.com, for more webinars. And thank you again for sharing it with everybody and supporting all of our amazing partners. Thanks again to HMR, Fox AE, OnPoint, and Stratejic. And again, Dr. Benson, you are amazing. And Miss Caroline, we're going to have you back as well, because I like the two of you together. This is a great duo.
Yeah, I agree. Caroline, I think we should go on the road together.
I agree.
Oh,
Well,
and by the way, I'm going to send you a couple questionnaires because I see that some people are asking for the questionnaires that I mentioned. So I'll make sure we get them to you.
fabulous. And also, we just got another comment. These are the sweetest comments. Dr. Benson, can you see this? Caroline, oh my gosh, you guys, thank you so much. Miss Ashley and Miss Becky, thank you so much. They think this is an excellent webinar. And that is the whole reason why we do this, you guys, is to help everybody out. Because again, you never know, it's going to help out one of your clients. And there's no way of us knowing if we did. We're just trying to put that out there for you guys. So if you think of a good topic, another speaker, just reach out to me. We'll make it happen. But Dr. Benson and Caroline, you're coming back. So we'll see you soon, okay?
All right. Thanks, guys. Appreciate it.
Bye, everybody.
Bye, everyone.